Welcome to our webinar. A good evening for the people in Europe and good something else for the people that are elsewhere. We have an interesting webinar today. We're talking about ethics in neurosurgery. We have three speakers and the topics are varied, but all have a connection to ethics in neurosurgery. We will start with our first speaker, that is Dr. Beverly Chesalam. She's a consultant neurosurgeon in Aga Khan University Hospital in Nairobi. She has a subspecialty interest in skull-based surgery, both microsurgical and endoscopic techniques. She has been a skull-based fellow at the University Hospital of Wales and a consultant neurosurgeon in Brighton and Sussex University Hospital in the UK. And she's also been a Weill Cornell Global Health Fellow in Tanzania. She has other interests in global health and teaching and clinical research. And she will talk to us about decolonization in our space. So that is a very interesting topic. If you have questions, please put them in the Q&A box, not in the chat. We will answer the questions at the end of all the presentations. No further ado, let's listen to the interesting talk of Dr. Chesalam.
Thank you very much for this opportunity. I hope you can hear me well.
Yes.
Thank you. I'm from Nairobi, and if it seems a little bit dark, that's just the mood lighting in the hotel room rather than ambient lighting. And I'm going to talk about decolonization and global neurosurgery, and I hope that the insights that I share are useful. As has been already illustrated, first I grew up in Kenya, then went and trained in the UK from med school right the way through until my skull-based fellowship, and then took a detour to do a global neurosurgery fellowship, which is in Tanzania, under the Weill Cornell guy. So that's an American program in Tanzania, under Roger Hartl, who's originally from Germany. And it just illustrates how we are from different places. And I chair global surgery in Surgical Society here in Kenya, and I'm a committee member in the WFNS as well. The views here remain my own because it shows the complexity of opinions when it comes to things such as ethics and perspectives. And so I hope that we'll have a vigorous discussion towards the end. One of the things that happened when I went to med school is that I rapidly realized that healthcare is practiced within a certain context. I had my identity as a Black woman growing up in a predominantly Black country, and then rapidly became a minority both in gender and ethnicity within the European context. And through that process, I noticed the power of language, the power of stories, and also how much things have changed in the last 100 years in what is considered acceptable language and how we consider ourselves as practicing clinicians. And these topics are emotive. And not always with the intended purpose. One of the major trauma centers, for example, instituted a coding system for trauma. And one day they shouted out a code Black, and in came in this big Black man. And what was intended by the people who set up the system was to say code Black means a critically ill head injury from trauma. But what was perceived was ethnicity. And I've had similar presentations where once one of my senior fellows was operating on a patient who'd come in as emergency, and he kept asking, what's my status? What's the status of the patient? And a lot of the healthcare people in the room were wondering whether he was asking about immigration status. He wasn't. He was asking about the sickle cell status. So even as we talk about the impact of our history on language, we need to understand that we may not mean the same things when we're talking. Now, colonial ideology has been here for many, many centuries, but in particular, we'll focus more what has happened in the last 150 years. This is a picture of 1914 of how the world was, with most of Africa and Asia being under colonizing European powers. Where South America and China don't seem to be showing that pattern. This isn't true of their history. People move from different places and develop different identities. This happened in parallel as neurosurgery was developing. And so if you read, for example, the history of Harvey Cushing, whom I celebrate in many ways, he also had very strong views about ethnicity that in today's world would be considered frankly racist, but that was a season of the time. And it's in that culture that we formed also our philosophies of how we practice health. And these are strong. I use here, for example, how strong names can be. If I said there is an old leader of an ancient kingdom who marries to form alliances and oversees a big population, we might embody one kingdom with science and development and another one with primitivity. Because of what? Because of language, of how we've learned to interpret how people think. So during the colonial phase, Kenya, where I grew up being under the English rule, the health models that we have today had their first roots then. And we were involved in writing a paper about how particularly surgical practice started. And whereas most people understand when we say about segregation in South Africa, colonial hierarchies were pretty much the same. They were segregated. The hospital that I work in is in an area where mainly Arab and Asian families would live, and they still continue to live there. So my patient population is not a true representation of the very country that I live in. There were hospitals that had largely white patients and hospitals that had Black patients. In white hospitals, you tended to find that they would be what you call the adventurer surgeon who would leave their European country and come and practice. And in the Asian hospitals, you may have had the not so high achieving surgeon and some of the local surgeons who had traveled with the Asian and Arab population. And in the African hospitals, there was rarely a well-trained surgeon. The vast majority were people who had learned by experience, who were taught very simple techniques like how to do an amputation, how to debride a wound. In many ways, very veterinary medicine of how do I treat you to get you back to work? Since then, we have looked at things like how our public agendas are in different parts of the world. There are places where we look at quality of life outcomes, where we look at patient engagement, and in others where we look more and want them to accept a more, live or die kind of pathology, health system, or something is better than nothing. The language that we also learned was alien to our peoples in terms of how we describe medicines, where treatment is provided, etc. And so that even as I practice Western medicine, I practice it in a way that is disconnected to the cultural roots of the areas that I practice in. Then we start to have the introduction of medical schools, and certainly in East Africa, the first one was in Makerere. But even then, the ability to sit fellowship exams was restricted to only England. And we even have documentation that showed that practicing surgeons at the time were very keen that colonies did not acquire the ability to conduct exams and that their syllabus should be restricted in what they train. So what's in a name? There has been a big evolution from public health to international health, tropical medicine, and global health. But all of them started from the idea that as largely Western scientists moved from one part of the world to the other, they encountered diseases and peoples that they had not previously met. But the challenge with the language is that many times public health was a them and us, international health was those people over there, buzz over here. Tropical medicine gave a sense of as Iman would say, exoticism, as though, the way we would describe mangoes and bananas and things from over there. And so the power of language has continued to hamper the models by which we teach. Global neurosurgery is probably about 20 to 25 years. And now this was a redefining of the identities and trying to say, no, if we're to change, the study must be inclusive and it should look at safe, affordable surgery, it should look at utilization, it should be interdisciplinary, and should be an umbrella movement. So rather than one population telling another population how to practice, both populations should have a say as to how priorities are set. But the geography still has issues when we're discussing global. So when you say, for example, global north and global south, somehow Australia has made it to the north despite being very south, as have a few other countries because of their geography. And what this underpins is, despite moving from what we've said about a colonial history, we've still maintained some of that in our definitions. People might say, well, it's because of how much income people make. That isn't necessarily true. There are African countries that have a higher GDP than other European countries, and the same is true for sections of South America. But they don't get to choose whether they're classified as global north or global south. And as we'll see later on, this has major ramifications on even our ability to practice. Another one is the low middle income versus high income. And this is once again an averaging out of societies and saying that this kind of society belongs to one income group and the other one belongs to another group. But I've said that there's a heterogeneity. Sadly, it's a very sad event that happened during COVID, but it exposed that no system was so robust as not to have been affected by effectively a viral illness. So it wasn't a major invasion or anything like that. But it exposed weaknesses in healthcare systems that showed that these labels that we had used were to our disadvantage, and that what is more useful is when we approach health systems as more heterogeneous entities, and we look at populations, individuals, patients in a much more refined way than these global brands. The hospital I showed there at the bottom is one of the hospitals in Kenya, which is one of our national hospitals. And it has quite a lot of equipment that, is comparable to many of the institutions that I trained in, but doesn't get the opportunity to be exposed in quite the same way because of the geographical collocation. Now, when it comes to surgery, when the Lancet wrote about access to surgery, the reality is both high income and low income countries, as described, still have the same challenges. We still have a mismatch between specialists and the services that are required. The challenges, though, are perceived in a very different way. So, for example, in a country like Kenya, you may have very many patients and few doctors. And in another system, you may have more doctors, but the needs of the population through age, etc., overwhelm the system. And so what you end up with is a rationing of the system, creating waiting lists. Or you have a system, for example, and I don't mean with any disregard, like America, where those who can afford get access. This is the same play, even in what are perceived as low-income or global South countries. There are places where there's no waiting list. For example, my institution, and 100 meters away in a public hospital, there's a major waiting list, even though it has more clinicians. So we need to have a further discussion about how we classify things. So the other thing that we have about global health is that there are two paradigms. One is the global health security measurement, and the other one is the humanitarian biomedicine. If we look at it from the global security, then if we define, for example, a type of threat, then we look at emerging infections that threaten wealthy countries. But if you look at it from a humanitarian, you look at more neglected diseases that afflict poor countries. So trauma, which is still largely represented in both countries, is seen as a threat more in lower income countries, and less so in the high income countries, but they consume a substantial amount of surgical time either way. So, but we need to change and move from this binary way of definition and so on and so forth as we go through the differences between the global health and the humanitarian paradigms. Now, the experience that I had when it comes to training is when we look at global neurosurgery, is questions such as, are some training opportunities more equal than others? I got the opportunity to be in Tanzania. Within 3 months, most Tanzanian neurosurgeons have had 300 to 500 craniotomies under their belt for trauma, infection, shunts, because of the volume of patients. But there are not many people who would leave a global north country and say, I'm going to Tanzania, I'm going to DRC to learn about how to operate in trauma. We are more likely to say, I'm going to teach. So when we're giving labels, we probably mislabel certain things. And instead of, if you were in Germany, for example, you might say one institution in Nuremberg is good at this, and another one in Würzburg or somewhere else is better at this. And so you would move your trainees accordingly. But when we come to the equity that comes with training, we have apportioned better training opportunities so to speak, in one part of the world relative to another. And even how we design the curriculum, we find that in a lot of global neurosurgery objectives, it can be more about focus on trauma, focus on infection. But the trainees there will tell you, we do quite a lot of trauma. What we want to know is, what are we going to do with our aneurysm patients? What are we going to do with our tumor patients? So even in how we determine what constitutes training, there are variabilities in the same. Then there's the differences in the opportunity and burden of pioneers. When I trained in the UK, my expectation is that somehow I'll become a fit in technique and personality to a unit that already existed. Whereas almost all the trainees that I deal with, even now in Kenya, are pioneers in the institutions that they work. So the training that we offer needs to adapt, to be different, to speak to somebody who needs to have business skills, marketing skills, community advocacy, etc., and to be acknowledged as such in how we give people access to platforms for presentation, etc. And then access to research, I'll discuss about that, and bearing the cost of training. Most African trainees bear most, if not all, of their training costs, including relocation fees. That has an effect on perhaps their ability to spend time doing research or presentations because they're using that time to generate income. Certification and the value of that certification. There's been a big concerted effort between the European bodies, the American bodies, Asian bodies to work with partnering with African countries, for example, to improve the certification process and introduce collegiality. But we're a long way off from seeing each other as equals. Discuss about setting priorities. And then the key thing, of course, is about patients' perceptions of quality of care. Because of the historical differences that we had, patients who grew up in areas that have been colonized, like, for example, my country, view certain institutions, certain doctors, certain names as superior in service. So Africa spends more than $1 billion every year seeking care out of the continent, even when that care is available in the continents. And that's one of the challenges of colonization and its legacy, where people can be told, yes, there's a hospital 5 kilometers away from you, and it can do your trauma flap okay, or it can clip your aneurysm. But because of this long history, patients would still fly themselves to Belgium or France, etc., to acquire care that they perceive as more superior. This one in a nutshell is about how do we perceive people. If I came and lived with you in Poland, would you see me as an expert or would you see me as an immigrant? If you came to Kenya, would I see you as an expert or as an immigrant? Because we are called those two different groups, different privileges. Even in training, if you're an immigrant, well, you've come to learn from us. Therefore, you're more likely to be put lower down in the training cadre, and we have less opportunities to hear your voice. You're more likely to be there to listen to our voice. And that just amplifies the difference and the idea that some people are more capable than others. We have a bit more task shifting without the caveats within LMIC projects. So if you're doing a collaboration with a global South country and you intend to do any task shifting, I kindly urge you to ensure that that is considered acceptable culturally and professionally with the body that you're working with. Because this is an area that has created a lot of problems because these same systems are not implemented in countries where collaborators may be coming from. Huge brain drain, I think that speaks for itself, and economic plans that include that restrict healthcare worker growth. Many of the African countries are guided by the IMF, and I compare, for example, at the end of the Second World War, the experience that Germany had to rebuild itself, and many of the other countries since then that have been dispossessed either by war, colonization, political instability. The restrictions that are imposed by some of these economic groups are so restrictive, even on the development of healthcare worker growth. So in Kenya, we have 2 neurosurgical programs that train, but we cannot absorb all of them into the public sector because the conditions that we have from the IMF limit expansion of the civil service, and that includes healthcare workers. So the most that they can do is either set up a private practice or go abroad. So even as we're talking about how do we make things equal, we need to be aware that there are geopolitical factors that restrict people's ability to work in their very own country. The
Dr.
editorial process is
Can you round off?
I need to wrap up?
Yeah.
Okay, so we have the same discrepancy when we come to telling the story. So the editorial process, for example, or even the language that we use in authorships and how they can dispossess people of the narrative of their story. This is a paper that looks at who's the first author or the last author. Even if you're from the global south and the story is about you, you're more likely to be sandwiched somewhere in the middle rather than to be a primary reference author. And if you get the privilege of presenting your work, it's less likely that it'll be on your continent with all the challenges that come with that. But it's not all bad news. The Romans did do a few things for us. One of them being our ability to communicate with each other and to have shared education models and to be involved in research. And there's an increasing plurality of identity. What my name is, my religion, the color of my skin, does not necessarily tell you the whole story about what I can contribute. And that's certainly true within the neurosurgical sphere. So to decolonize, we need to increase the value of each other. We need to maximize our agency and capitalize on what we can do. And there are many collaborations. This is just one example in neuro-oncology where the European bodies and American bodies are working with us to publish and host conferences, as is St. Jude's. These are other bodies that we're also working with, like a G4 Alliance. And there are very many ways that we can work together. We can co-site conferences, we can have mutual exchanges, we can strengthen our training by having open conversations, open access to tell our stories, and review how we do our authorship process. I was going to talk about this, but now I'll hold on to that. But hopefully there'll be a wider discussion at the end. Thank you.
Thank you very much for that amazing presentation. It ticks a lot of boxes of my personal experience, so thank you.
Yeah. Okay, it's my pleasure to introduce the next speaker, Ingrid Miljeteg from the Bergen University in Norway, and she's a real professor in medical ethics with a special interest in ethics in low-income countries. So I'm very happy to hear what we will talk about. So please, Ingrid.
Yeah, hello and good evening, everyone. Let me just start sharing my slides. Let's see. You see my full screen or my presentation mode?
It's a full screen, actually.
It's a full screen. Okay, great.
It works.
Okay, great.
Mm.
Yeah. So thank you for inviting me. And you might wonder why, as Beverly pointed out, why do we ask someone from Norway talking about this? So Ruby asked me, based, I guess, on my research interest and what I've been working on for the last 20 years, and also what I like to tell you about my experiences, especially from East Africa. So my university and my group, the Bergen Center for Ethics and Priority Setting, we've been working very, very closely with colleagues especially in Addis Ababa University, where we also have an ethics center, and where we have worked together to try to map out what kind of ethical challenges are clinicians in low-income settings experiencing, because this has been really a neglected area in the field of ethics. When we talk about ethical challenges, we can talk about that at different levels, like the macro level. For instance, here, should neurosurgery actually be prioritized over other healthcare services? That's something our policymakers, politicians, and also you as clinicians needs to be involved in. Then if we step one level down, maybe at the hospital level, but also at the regulation level, a question that comes up is, how should the clinical guidelines be formulated? Should there be one standard like in Sweden, and another standard for the same conditions in a low-income setting? And if we really dig into the micro level, where I've done most of my research, then we come into the bedside dilemmas, the medical ethical dilemmas that you all know from your own context, which also, of course, arise in a low-income setting. But as I will show you, I also like to point at some differences there. So going back to my own experience, I did my PhD in Indian neonatal and obstetric units long time ago, looking at non-medical factors influencing decision-making for sick and premature babies. and then continued with a more focus on how to teach medical ethics for our students in Norway, but also in other contexts. So I've been working with at least this people here you can see at the pictures. And the first batch of collaborators in Addis Ababa in the first training of trainers in medical ethics course, it was a three-year long training. Many of them were neurosurgeons. So we collected a lot of cases that I found ethical challenging. And I really, really learned a lot from them. They were really trying to push the process of including medical ethics in the curriculum for the students and also in training during specialization. I also lived for several periods in Tanzania. So this is the picture of the students that I worked with last year at Zanzibar when I lived there. And I think, as you pointed out, Beverly, the collaboration here is extremely important, and in a field as medical ethics, I'm not an expert on anything, but I'm maybe good at asking questions. So that's how I have learned from my colleagues, and we try to develop a field. So training has started in several institutions. But a little bit more about the context. These numbers, what is it? So the first is 8,637. That's how many US dollars we use per capita on health each year in Norway, while the 34 is what Malawi uses. You see the extremely difference in the amount of funding that we have for health. And we have a public healthcare system, we have a welfare state, but also in that number 34, it's also out-of-pocket expenses and a lot of donor funding. And how should the government in Malawi decide what they should fund when it's so scarce of resources? So that's the kind of the money part. Then the other numbers show how many physicians do we have per 1,000 population. So we have over 5 physicians per 1,000 in Norway, 3.7 in OECD countries, while in Malawi it's 0.02. And so what should these physicians do? Should they be neurosurgeons? A little bit more about the context, because it's a difference in many ways. It's a lot of things that are the same, but the global burden of disease in many low-income countries are high, not only because still all the infections and maternal child health interventions still play a great part, but also because of NCDs is really increasing. And we see that in African countries, the prevalence of deaths in traffic accidents is the highest in the world, as this picture might illustrate. There's a lot of traffic accidents, and also in the hospitals it's crowded. This picture is from Malawi as well. It's not in the ward, it's in the corridor outside the ward where the neurosurgeon patients are treated. And just to give you a bit more background, maybe I'm painting it a little bit black, but I've seen this so many places also that even if you have the surgeons there, you can do the surgery, you might do not have a proper ICU department or equipment or staff there. And also we know that morphine or other pain relief can really be a challenge to get. So it's not only to implement surgery, but it also depends on the whole system. And then I like to put more effort on this public health or policy level. What should we prioritize? What should these $34 be used to? And in many low and lower middle income countries is a process now of defining and extending the universal healthcare coverage, because we know that a lot of the costs for health is out of pocket, and it can be a catastrophic health expenditure. So many countries are developing their universal healthcare package and then discuss what should we prioritize. What population should we cover? How many should be covered? what kind of services should be covered, and also what to do also to protect against poverty. For we know that sometimes, even if services are not very beneficial for patient, cost effective, people still want it. So for instance, Thailand decided to integrate dialysis treatment for end-stage renal failure in their universal healthcare package, not because it has a great health effect, but it protects against poverty because people will buy it and get poor. So I tried to look at neurosurgery, what kind of services have been included in different packages around. I couldn't really find much. And in the disease control project number 3, they did a lot of cost-effective analysis of different interventions in different settings. And the only thing I could find that is cost-effective when you look only at that is to bore hole in trauma patients. So that came out as a cost-effective interventions. So if you just choose where you get the most health for the dollar spent, neurosurgery is really not the field you prioritize. So I think this is a question for you, because I know you Magnus will talk about missions and these things. What are you actually doing when a country like, for instance, Malawi or Ethiopia decide to prioritize vaccines, safe maternal care, maybe some introducing drugs against high blood pressure? What happens with the system when you come and want to do some neurosurgery? So this is just a provocative question to you. Then going to the bedside, as a few years back in this project in Ethiopia, we really searched for literature, what kind of dilemmas do we need to prepare the medical students for? And we could find very little literature. So we did a large study among 1/3 of all the registered physicians in Ethiopia about what kind of dilemmas are they experiencing and so on. So I just want to briefly show you a few of those results, and also some results from other PhD candidates that I'm supervising within this field. This table, you cannot read it, but we had several situations where we asked them, do you experience this ethical challenge sometimes or often? And what came up the top was this, that limitation of resources required you to make a difficult choice. And secondly, that you couldn't provide the treatment that you really wanted because the patient could not pay. And this were only in public hospitals. Then other well-known dilemmas like decision-making, should you tell or not, who is deciding, religion, unethical behavior among your colleagues, and so on also came up. But when we did also a lot of qualitative interviews, the whole issue with resource scarcity kind of wraps all of the other classical ethical challenges like end of life and abortion as well. So I like to focus on that. Here is one citation from one of the participants. Usually in my duty, I face situations due to lack of resources like beds, operation room materials, sometimes oxygen and other resuscitation material. It makes me choose the most critical patient who is going to suffer immediate complications. But in the end, those who have been labeled low risk later come with more complications than those who were given priority. And I feel bad. Whatever you wanted to do is limited on what's available at hand. And I think maybe some of you can experience this yourself sometimes, that you actually do not have what you need. And that feels really bad for clinicians. But it also leads to other dilemmas, because you know that this family, it's no welfare state, it's no one helping this family. So here was a situation where the child needed surgery, and it was in a local hospital. So it was possible to get some services in the city, larger city, but the physicians knew that these this family was very poor and had seen others selling their land, getting debts and so on. So the dilemma was, should I tell them and risk that they fall into deeper poverty, as I know they will listen to me, to what I tell them, or should I not tell and deny this child the only option that is there to live? And as you, of course, understand, this is an ethical challenge for this physician. Should I tell, or should I try to protect them from using their money? And maybe the outcome of the surgery was also questionable. Another study we did, not among neurosurgeons, but among nephrologists in sub-Saharan Africa, we asked them a lot about what services they provided, and especially concerning end-stage renal failure. And most of them didn't see their patient 1 year after starting the treatment, because even if it was for free, there is a lot of additional costs with treatment in public hospitals. We've seen that also in Tanzania, where we interviewed families with a family member in dialysis. Many of those we talked with had taken their child out of school, or even reduced from 3 to 2 meals to be able to afford all the additional costs of this kind of advanced dialysis treatment. And this figure also shows some of this, that it's not enough resources to really provide the standard care. And you are very concerned about the costs for the patient. Like, cost for the patient is important for me when I decide to use or not use an intervention. So it's not only the medical condition, but it is also how will this affect the family. And this lead to that they use different strategies to try to limit the costs for patients. We asked about the same for, do you do something to limit costs for the public institution? But it seems like they do more to protect the family or the patient for costs. And of course, this discharging patient earlier, limiting testing, limiting other kind of diagnostic strategies, and providing second best treatment is very, very common. So in many ways, reduced resource scarcity lead to a lot of complications for the clinicians. One thing is, of course, the uncertainty when you cannot get all the diagnostics that you need. That makes it more uncertain, and you need to still make a decision. You don't necessarily know exactly what this is or how it will progress. And you are in a situation where you know what to do, but you cannot do it because you don't have it, or you have to do something that you know is not the optimal for the patient. Many also explained about how they had to choose between individual patients, like who should get the bag of blood, who should get to the OR, who should get to the ICU. So many in need, but you cannot provide for everyone. So you have to choose between patients. And then without guideline, mostly that will lead to the first come, first served. And which we can, of course, question from an ethical side, is that always the best way of doing it? Then communication challenges, especially with families, what to say, what to not say. And this new steward role, that you are a steward, you also feel responsible for the economy of the family. And in many settings, the legal regulations are less developed than what we are used to. So if someone accuses you for something, and some of the neurosurgeons told about people that accuse them for euthanasia when the patient is brain dead and they would like to withdraw the ventilator to use it for someone else. It's not, they are not, really do not feel protected. So it goes directly to court, and they've seen colleagues imprisoned. So there's also a fear of doing something, even that you, for instance, this end of life concerns that you like to withdraw and even withhold. But I've seen several brain dead patients in the ICU in different hospitals, and that's also very morally distressing when you know it's a lot of other patients who need the same ventilator. I'm not sure how familiar you are with this discourse and concepts of moral distress and moral injury, but we do a study now in Malawi among carers for a trauma patient, and we see the level of moral distress is really, really high. And also, I know I will soon stop, when we ask, do you regret your choice of profession? That's also much higher than we can expect in other settings. And this is really alarming, especially when we know that we need all the healthcare staff that we can get. I will just rush through this last then, because I also want to highlight when we asked not only the Ethiopian physicians, but also in Tanzania and Malawi, what would you want? What's needed for you? And of course, more resources and especially more qualified staff, but also the lack of training and support when it comes to handling ethical challenging situations. They ask for that. And context-adjusted policies and guidelines. For instance, the lack of guidelines for DNR and withholding and withdrawal of life-prolonging treatment, treatment of anencephalic babies and all that, which is very kind of an area no one really has touched, I would say, in many low-income settings, these kind of ethical guidelines, and also when it comes to legal regulation. And with an increasing awareness in the population of health and their rights, also the ethical challenges connected to all kind of medical intervention, especially interventions like neurosurgery, ICU treatment, cancer treatment, where we can actually keep people alive to a cost maybe, but also to improve, of course. People need to know more about this as well out in the public. So thank you.
Thank you. Fantastically interesting, especially with all the economic side of it. But I think we need to go on.
Yes,
Yeah.
and now it's up to Dr. Magnus Tielsen to talk about his experience in working abroad. He is our chair. He's the chair of the Global and Humanitarian Neurosurgery Committee and founder of SANC, and chairman Swedish African Neurosurgical Collaboration. And he will talk about his experiences and the ethical sides of doing missions and teaching abroad.
Okay, thank you so much. You can see the slide? Yeah. Perfect. So, there. So this is my disclosures, and I'm not an expert at all how to work in a low resource setting, because I'm not living there. But so the reason for this talk is a little bit to give an expression about how it is for somebody from EANS to go down there and the things you meet. So that's my experience. And I've been there as a guest. I'm a guest neurosurgeon. I'm a guest educator, and this is the focus of the talk. So my personal background, as you said, I've been a medical advisor for a neurosurgical governmental project in Malawi for many years with Patrick Kamala. I think he's here in the guest list even, and also been founded and the president of this organization that is working in West Africa, that is volunteer organization. And as you know, there are the medical ethical key points I always talk about during the training courses in Europe. You know them well. All neurosurgeons always struggle with the good against the do not harm principle, and we have the justice and autonomy. These are the guiding principles of our work. And I mean, there are the guiding principle here in Sweden, just like in Africa. And the conflict appears when this principle kind of get against each other, which they do now and then. And this is well known. We have a very unjust availability of surgery in the world. This is from the Lancet Commission. We shown many times, showing a large proportion of the population without access to surgery, especially in sub-Saharan Africa. And we've also seen the map with the neurosurgeon. This is from a few years back, but you can see the number of neurosurgeons in absolute numbers are very, very small in this part of the world, but very, very high here. So there is a very, very big imbalance in the world. So there is a justice problem on a global scale, so to say. And the first thing, if you go down to Africa, what your colleagues ask you is it meaningful to go? I show that this picture is a drop in the water. There are also many patients, and the need is staggering. So what is the mean to go there? What difference does it make? Is this kind of medical tourism? Is this kind of medical colonialism, as mentioned? So, but I have two answers of that. And number one is very simple. It's that all patients matter. And if somebody asks you, can you go 2 weeks to another continent and save some persons? I mean, these persons are, of course, as valuable as any persons. But that the most important thing is that the accomplishment that you are left when you leave. What difference can you make at the long run? So on the left there is the example when we started in Nigeria. You can see this roof-held microscope. We got it down in 2019. It's put up in the roof, and this was the first microscope that we had. And you can see the people here can look at the video screen and actually learn from the surgery. They're not participating in, and this microscope is still working. It's still working after all these years, and there has been a tremendous change for that institutions. So I mean, sometimes quite small things or small can make a big difference, and that is the thing you have to keep in mind. And there are so many things to think about the collaboration forms. I think we have an advantage when we come from Scandinavia because we are very used to flat organizations. We are not in a special hierarchical environment, so we are might be quite used to collaborate on a flat scale. And I think to have these collaboration forms are the key to success. And even more important might be the personal knowledge about the people you're working with. And as we in SANC work, we always work invitation. We never push anything. We are asked to come by people we know, and we try to respond to needs as good as we can. There are a lot of other things with the legal clearance that has to be fixed, but the financial matter is always there also, and one also has to be aware of it. In some of this environment, there is also quite high matter of corruption that actually also have to be aware of, that you're not used to, and that has moral implications. And I think for me personally, to go and work with people, with the groups in the other countries, it doesn't matter where it is. The most difficult might be the selection of patients, because which patients of all these patients are we going to do? Are these kind of educational patients that are the best to train for further notice? Are these the hardest case that somebody wants you to do because it's so hard and it's so difficult, and maybe it's too difficult even for us, for anyone in these kind of settings? Are the cases chosen by financial circumstances, and also there are different priorities? And for me as a guest, or for anyone who guest, it's very important that you can keep the right to refuse if you don't feel comfortable with it, because sometimes you might think that I can't do really the best thing in these settings. On the left here is brainstem tumor. I think we did in Malawi this summer, and then last winter. And I mean, she had some, and I think it went fairly well. And on the right, it's a glioblastoma. It's not from Africa, but we had a discussion with priorities in Sweden. The malignant tumors are very highly prioritized, like in most, to have operated and treated, but sometimes in a resource setting, if you don't have anything to give them, you can't give them radiation or any treatment afterwards. Are these the patients you should prioritize? or maybe some others, especially if you have to take resources for treatment abroad, for instance. Should you send a patient with a glioblastoma abroad for money from the state to get irradiation to live a few months more? That is not totally clear. So all these things, and this is exactly what Ingrid also touched upon, and Bevel as well. I mean, the resource scarcity, you can't do your best, and that kind of frustrating, and you have to cope with that in some way. The patient autonomy is very important, and that is much more trickier if you are because there are, of course, cultural differences. You don't understand the patient, you're interpreted, you might be not even involved in the discussion about the risks. There are language barriers, and the only solution for this is trust. You have to have trust. You have to know the people you work with, and you trust them. Otherwise, it will not work. And because to operate a patient without the real being really informed or real understanding things is very, very difficult. And this is a lady from Gambia with her, and she spoke a language that nobody, even in the hospital, spoke. She had to be translated for another person. But she was very happy after it was not a big surgery on the child. It was encephalocele, but she was very happy afterwards. But before, she was very, very stressed, and that is a big problem. I don't know really how much information she got, because the translation was done by a relative, and you never know really what they say. So that is also like ethical stress on you dealing with the patients. And as I said, you have different treatments you have to do, and because you have different resources. And you have to make the best of what you have, and you have to learn. And I always say the same, that it's not only a teaching experience, it's also always a learning experience, because you learn how you can do things otherwise, and you learn a lot from that. And you go through different phases of reaction. It's a little bit like a crisis reaction. You have different phases, when you're sometimes shocked by what happens, and then you try to reorient, and then you have to build up something again. And you have to accept imperfection. I mean, it's imperfection everywhere in the world, but you have to do it. I mean, this is from Liberia, when we got the oxygen. We had problem with the long surgery because there was no more oxygen left, and the patient was still on the ventilator. But they had to carry the oxygen tubes many stairs up, but it managed in the end. But these things are, it's exactly that Ingrid mentioned, the same things, that was what the doctors always felt. This kind of, you know what to do, you know what you could do better, but you can't do it because you don't have the real resources. And you have to adapt to that in a way. And this is horrible, like avoidable losses. This is a young boy that operated for a tumor that actually died by complication to the intubation of the tube because it was the wrong tube, and she got medicinitis. So died from a totally avoidable reason, from big surgery. It's something that you never experienced, but there was not available the right tubes. That was tubes they had, and the surgery was too long, and this was what happened. And you have to deal with that as well. And you have to think about the follow-up and think through before. This is another example from Gambia. We usually show it's a benign tumor. This is a polycystic tumor. It's a young girl. We operated upon it, but it's quite close to the pituitary, and the patient got diabetes insipidus afterward. And I hadn't checked that they had desmopressin. I should have done that. I should have asked them. But when she got it, where is the desmopressin? We don't have any. And there was a kind of panic, and we managed to get it from a pharmacy. But I put her in, and she also had hemiplegia, direct surgery, and we really made this almost end up in mystery, because I haven't really thought it through. I just thought we do the surgery, we do it, but I didn't thought about all the consequences of the surgery. But everything ended up well, so I always show this. So this is the video of her. I got it 2 months after. He was off the desmopressin and was a very nice child. So that what was this was the best this yeah. So this was the best video I ever get in my life, because that was such a relief to see this child, because we left her, and that was also because of the problem to follow her up, because we left her hemiparetic diabetes insipidus, and I didn't really know how it would end up with, and but then and she was transferred to another hospital, but then she ended up good. So all these things are very, very hard to deal with, and very, very hard to balance in the right way. But I think it's very, very important, at least, to be aware of and understand of the ethical conflicts and a little bit of what they make into your own mind. Because if you're not that, it's very, very hard to cope with them. So you have to just be aware of them. And I mean, you can't reach perfection, but you have to deal with this, and you have to work with it all the time. But I don't want to be too negative, because I think the most important is that we can all make a difference. And to the right here are the two first Malawian, you talk about Malawi, Ingrid, and these are the two first trained by Professor Kamalo in Malawi, and who was graduated last autumn, last December in Addis. And that was a very, very happy moment for all of us. And that makes a big difference. I mean, Patrick was the only neurosurgeon in Malawi for many years, and now he has built up a clinic with 4 consultants and several residents, and that makes a huge difference. So the worse it is, the more difference you can make. That is the positive thing to take of it. So I also want to just mention that we have worked in EANS with guidelines, how to work, doing missions to work with low-income countries from EANS sides, and we're working together with a lot of people in all over the world, and it's a work in progress. And the main people have been Nicolo to the left, and Professor Uchi from Nigeria in the middle, and Vicky has done a lot of work. And we hope to publish this in the near future. We had a very nice workshop in Sofia about it, and I think this will be some help also for people to get started, because it's needed. Thank you very much. That was all.
Thank you for your presentation. I think it is, choosing these topics for this webinar. I think it is good to talk about things that are difficult, because that brings progress. And I think talking about ethics, talking about decolonization, talking about difficult issues is extremely important, because it's not only, operating and thinking that things will just turn out fine. So thank you all three for the amazing talks. I'm just checking if there are any questions. Well, first of all, excellent. We have congratulations from Dr. Gail Rousseau talking about the program. So that is great. And Dr. Park, thank you for the congratulations. There's a question. Let me see. I need to kind of, I do have a question from a spoiled position based in Switzerland.
Oh.
Here people have lost the sense of the finiteness,
the end of life.
Finitus of life. Thank you. No one is allowed to die. Society has completed a wonderful naturalistic fallacy. We think we must do something just because we have the possibility. So having the financial and personal resources legitimates performing surgeries. This leads to massive healthcare costs, which are exploding and more represent a significant burden of society. One question, do you know about approaches of ethically responsibly limiting neurosurgical indication? That is one question. And the second question is, who can be held responsible to establish a sensible neurosurgical indication making? Okay, so which one of you wants to answer the first question? So do you know about approaches to ethically responsibly limit neurosurgical indications? Yes.
So I was just going to give to say, first of all, there is no one way to do it. So in the population that I practice, there's a huge variability in what you consider what is ethical, what is good quality of life. We have some communities that believe that life is just a transient experience, and what God wishes will happen to you. In those families, we have a hard time when we sedate patients in ICU, because for them, the process of grieving has already started. And we have another group where you must do everything so that you can have closure within the context of what is socially acceptable within your community. The hardest conversations that we have is in a plural society. How do we have these conversations, especially in cultures like ours, where speaking about death and planning for catastrophe is seen as a taboo? So even before we think about just neurosurgery, we have wider conversations, because for example, in our culture, we understand when the heart stops. We don't understand so much when the brain stops culturally, because we still see the heart. And thank you to all the movies that still show the beating heart. So we associate life with machine working and showing signs of life. And when you say brain not working, we are having to use more and more resources to explain that to our families, because we haven't had that conversation before we came to hospital, and that's a cultural context. Yeah, that's what I'd say. There's no one answer, and so you have to remain flexible with your patients.
Yeah, I think it's a fantastic question. So many aspects of this. And I think the number of neurosurgeons in Europe and places that's very high increases the indications. So and you have a surplus of doctors, you get more indications, and that is quite natural, because and also this is one thing, and also the increased safety of what we're doing kind of broaden. We operate older people, we operate sicker people in the Western countries, so it's kind of self-replicating thing, and it has absolutely ethical consequences. And if you see in a lot of the diagnosis, when you really think about old people with gliomas that you do surgery on, and there's also financial implications in some places, because when it's business in the surgery, you broaden the implication. So I think this is amazing questions. I don't have an answer how to end it, but I mean, to have a very sound indications is a good start. And we know that there is difference in different healthcare system. If the healthcare system means more financial gain for the persons who doing the number of surgery per surgery, it will increase the number of surgery. And that is a bias that I don't think it's conscious, but I think that is how it works, because we are humans. And we kind of bias ourselves to different.
So I also like your question, or this question, a lot, and I think it really points at research and also experience from high income settings, where you ask what's the most common ethical challenge you are facing, and almost everyone except in psychiatry and addiction medicine says overtreatment. We are going too far, especially with the frail and old patients. So I think this is one of our time's major ethical challenges. And so there are some ways to kind of go into this field, and I've done that myself in several departments now at the hospital. But what we know is that we need people to talk about ethics. We need to have a system where there is room, where the leaders support, that you sit down and really discuss what's the benefit for this patient. Are we prolonging terrible death for this patient? What kind of pain are we kind of imposing on this family and this patient? And to really sit down. And just 2 weeks back, I attended a neurosurgery and neurology day where they discuss all day, and we talked about this, and they said, but we are so busy, we don't have time to sit down and discuss. And they told me about all these examples of really old patients with some kind of head trauma. And they also said, we know the prognosis is really, really bad for this patient group. So they knew, but they say we are too busy to sit down and reflect and discuss. you know. And I have to say one thing, in the end, it came out, but it's also very interesting surgery to do. So I think in this also we need to be aware of the drivers in ourselves. That, and I think you pointed at that, Magnus, that you can go somewhere and you can do surgery you will never be able to do at home. And what's our personal interest in continuing very, very far, or doing things that we might not really think is the ethically best if we get time to reflect with our colleagues.
Yeah.
Yeah, thank you for all the answers.
Mm.
I don't see any, oh, hold on, yes. Helpful insights. So do you yourself have, to all of the speakers, do you yourself have anything you want to add to this discussion? I mean, personally, I think we need to repeat these ethical aspects and to have them more often discussed in a webinar, and maybe even with live audience, asking questions, not only typing, to make it a lively discussion. But is there anything that you would want to add to whatever the other speakers have said, or?
No, I must thank the other speakers, because I think it was very nice to have these different views, and I think it kind of worked out well for me personally, at least. I learned a lot. So thank you a lot.
Thank you.
Yeah.
To you too. Mm.
Okay, well, we are 7 minutes over time, so we will need to round off. But thank you, everyone, and hopefully next year we'll get some additional presentations about all of this. And thank you very much. I really, really enjoyed your talks. Thank you. Have a good night. Bye-bye.